So hi everyone, thank you for being here. I'm delighted to be here with you, and I would like to thank TransplantChild for the opportunity to discuss with you the vaccination in solid organ transplant candidates and recipients. I'm Patricia Costa Reis. Together with Dr. Ana Rita Santos, I work at the Paediatric Nephrology and Kidney Transplantation Unit in Lisbon, Portugal, and I'm also a member of the National Committee of Portugal on vaccines, so it's really a topic that I really like. So first, I would like you to have a global idea of vaccination around the world. As you know, vaccines are really one of the most important public health measures that was established. And because of them, we have eradicated smallpox and we have decreased tetanus and diphtheria in several countries in the world. But the political and the social conditions of the countries and the communities are going to really determine the success of the vaccine campaigns. And for instance, we can think about the polio eradication campaigns in Pakistan, Afghanistan, and Nigeria, the examples that you can see in this slide, where they are still struggling to get to the vaccines to all the community and to decrease the levels of these diseases. With the vaccines, what is happening in the world, what is happening socially and politically with the different communities is really going to have an impact on this public health measure. And one example is what happened in Madagascar with the measles outbreak of 2018 and 2019. And here we have elections, and after elections we had a conflict, an armed conflict, insecurity. We had hurricane season, and lots of communities were geographically isolated, and it was difficult to get the vaccines to everyone. And the last measles outbreak in Madagascar was in 2003 and 2004. So we had a huge amount of population that was didn't have memory for measles, and so they were susceptibility for the disease was there. So in 2018, and there was a huge measles outbreak, and several children were really malnourished, so the death rate was high. So what we accomplished with vaccines in one moment, it really can be diminished if we don't continue to give the necessary strength to the vaccine campaigns all over the world. So this is something that we have to have in mind all the time. But it's not only in Madagascar and in the countries that I was alluding to, but also in the US, the measles outbreaks really happen. We have in 2000, measles was declared eliminated from the US, but then in 2014, they had several outbreaks. And in 2019, the scenario was even worse. And it's not also in the US, but also in Europe, as we all know, we had lots of measles outbreaks, for instance, in Ukraine and in France. In France, from 2017 to 2018, there was a more than 400% increase in measles case, and these are data from WHO. And all of these, we have to think about the confidence in vaccines, feeling that there is in the population or not, and not only the anti-vax movements, but also the people that have hesitancy in get themselves the vaccines or their relatives, and we are talking about their children. And it's very important for us as MDs to try to understand these movements and try to establish the best way to improve confidence in vaccines in our communities. We are really far away from what happened in the 50s. So in the 50s with the polio, everyone knew what polio was and the consequences of polio. So when Salk created an effective vaccine against polio, this was considered a major accomplishment for a public health measure. And there was the entire communities wanted to get their children vaccinated, the polio pioneers, the March of Dimes. And even when there was, as you know, the polio vaccine from Jonas Salk was a live attenuated vaccine, and the company had some problems with some lots that were not correctly inactivated. So there was vaccine polio and some of the cases with the really important consequences. But even after that happened, the confidence in the vaccine was huge. So what I was saying is that in terms of confidence in vaccine, we are far away from what happened in the 50s. So in the 50s, everyone knew what polio was and the consequences of polio. And so when Jonas Salk created a live attenuated vaccine that was effective against polio, there was this huge confidence in the vaccine, and we had the polio pioneers, the March of Dimes, and everyone really wanted their kids to have the vaccine. And there was this terrible accident. One of the companies that produced the polio vaccine didn't attenuate it well, one of the lots, and some children got sick from the vaccine, and they had important consequences because of that. But still, after that incident, the confidence in the vaccine was huge, and the population continued to massively vaccinate their kids. So when we think about confidence in vaccination, sometimes we thought that the problem was that if in the community these diseases are not frequent anymore, people don't understand why we need to continue to vaccinate, and that probably would be a reason for us to have lower immunization coverage. But then the pandemic hit us. And with COVID-19, we know what the pandemic and what the disease is and what is the effects of the different variants, and people all have friends or themselves got the disease. And this was marvelous because new generations understood really the importance of vaccines and of science and of healthcare. But we still have not only anti-vax movements, but hesitancy in vaccination. And this is in every single country, in every single community, sometimes inside the same home. So we really have to address these issues. And one of the major things is really to study confidence and how to improve confidence in vaccines. The London School of Hygiene and Tropical Medicine has been doing that, and they have the Wellcome Trust that published the data in 2018. And from this data, in the world, 92% strongly agree or somewhat agree that vaccines are important for children. But in Europe, there are some countries and that the confidence levels are much lower. For instance, in France, for the influenza, almost half of the responders of this questionnaire answered that the flu vaccine is not important and that the flu vaccine is not safe. This is also data from the Wellcome Trust, and here you can see globally, this is not only the influenza vaccine, but globally, in France, 1/3 disagree that vaccines are safe, and 50 to 20% disagree that vaccines are effective. So we really have to address this issue, and this is going to be important for our patients that are immunosuppressed. I would like to show you some results from an Italian 2018 study about parental vaccine hesitancy. And as I was telling you, it's not really just the anti-vaxxers that refuse all, that we have lots of people that refuse but are unsure, they delay, they are hesitant, and we have to address this question. So in this 2018 study from Italy, 84% were pro-vaccine, 16% were vaccine hesitant, and just 0.7% were really anti-vaxxers. And this is one of the major things that I would like to share with you, is that pediatricians are considered a reliable source of information by most pro-vaccine and hesitant parents. So pro-vaccine in 97% would say they rely on the pediatrician's opinion, and hesitant parents would say 83% of them that pediatricians are really a reliable source of information. So we really have to be well informed about vaccines. And the main factors associated with hesitancy were not having received from a pediatrician a recommendation, having received discordant opinions on vaccinations, having met parents of children who experience serious adverse reactions, are one of the major factors. So now let's really focus on the topic of the webinar, that is the vaccination of our patients that are immunosuppressed. And the immunosuppressed patients are, of course, much more vulnerable in a community with a lower vaccination coverage. So all of this is important, and we that work with the immunosuppressed have to be advocates for higher vaccination coverage in our communities. So immunosuppressed patients have low levels of vaccination coverage, and we are going to address this in the next few minutes. And of course, the physicians responsible for the care of immunosuppressed patients must have expertise in vaccination, and this is something, of course, that all of us understand. So the immunosuppressed have a high risk of infection, and if they get vaccines, and if the vaccines really can give them protection, then we are going to decrease major infections, emergency department visits, hospital admissions, and of course, morbidity and mortality. The problem is that the immunosuppressed have a very low vaccination coverage, and this happens because of different reasons. For instance, due to chronic disease, vaccines are not perceived as a priority. If our patient is really sick, in hospital multiple times, this child doesn't go regularly to the pediatrician or the family doctor and usually just sees the specific doctor, and vaccines are not discussed as they should be. There is also the problem that some teams have doubts about the efficacy and safety of vaccines in immunosuppressed patients, and there is this fear of triggering rejection. And it's true that there are not enough studies to understand completely efficacy and safety in some cases. And all of that are factors that are going to really decrease the coverage in the immunosuppressed patients that are very vulnerable and should be our main target in terms of vaccinations. And we have this central conundrum because the immunosuppression state determines a higher risk of major infections, but at the same time, it also determines the inability to prevent infection with immunization. So the greater the degree of immunosuppression, the less likely is the patient to respond to a vaccine. And there are several factors that will determine the vaccine response in a solid organ transplant recipient. Of course, the underlying disease, what are the immunosuppressive drugs that we are using, and what are the doses that we are using. If we have a rejection, of course, we are using much more immunosuppression, and the patient probably will have a less ability to develop immunogenicity with the vaccine. And then we have other comorbidities. Some patients will also have an immunodeficiency or asplenia, and then we'll have lower vaccine responses. So it's really, really important to plan a vaccination strategy. And we sometimes have to use different schedules, use passive immunization and drug prophylaxis, just to protect our patients from these diseases. So today, in the webinar, we are going to talk about general principles, we are talking about different vaccines, and then we also talk a little bit about the research agenda. Different recommendations from different societies are published. In 2019, the American Society of Transplantation published these recommendations that I highly recommend. Of course, we also have the data from CDC, from ECDC, and from our different countries. And in these different topics that we are going to talk today, I'll try to give you a clue of what's going on in the different countries, mainly in Europe. So, the solid organ transplant recipients are, of course, with increased risk of complications of vaccine preventable diseases. And we really should make sure that transplant candidates and their close contacts have been fully vaccinated prior to transplantation. And this is one of the major ideas that I really would like to transmit, is that the pre-transplant period is an important window of opportunity. Of course, vaccine responses may be diminished in some patients during this period because of their chronic kidney disease, chronic liver disease, but after transplantation, the response is going to be even lower. So we really have to have these children immunized before transplant. And another thing that is really important is that we should immunize these children early in the course of their disease, as early as possible. So before transplantation, we really have to review the patient's vaccination and exposure history. We have to keep the national vaccines plan updated, and it's different from country to country. And we have to vaccinate in the early stages, as I was telling you before, of chronic kidney disease, for instance, in order to achieve a better immunological response. And we do this, and I think the majority of transplant centers also do it. At the first transplant clinic visit, a vaccine strategy must be initiated. We have to have a plan for each child, what is going to happen in terms of their vaccines. And at the time the patient is listed for transplantation, we will address again the vaccination status, and the implementation strategy is reviewed. So this is really important, and the plan has to be put in action since day one. And we have to anticipate vaccination and boosters if necessary, and we have to check the titers and make sure that they have protective titers, and if they do not, we have to have a plan about it. So the main ideas, both inactivated and live vaccines, can be given before transplantation. The recommendations now is really to wait at least 4 weeks between live vaccines, live attenuated vaccines, and transplantation, and wait at least 2 weeks between inactivated vaccines and transplantation. After transplantation, what should we do? So this is different different centers have different practices, but the main idea is wait at least 3 to 6 months after transplantation to restart vaccination. Of course, the best option would be when the patient is in maintenance immunosuppression, so lower immunosuppression, then we are going to have probably the best response, and it's going to be more immunogenic. But sometimes it takes longer to get the maintenance immunosuppression, but the majority of centers at 3 to 6 months, they restart vaccination if that is indicated. The exception here is for the influenza vaccine, so we can use the inactivated influenza vaccine 1 month after transplant. If we are in the influenza season, the risk of having the disease and having the consequences of the disease are higher than the risk of giving the vaccine. So the majority of centers, and in the 2019 recommendations, it's really stated that 1 month after transplant we can give it. So after transplantation, we can administer all vaccines of the National Vaccines Program except for the live attenuated vaccines. And the immunosuppression drugs that we use, of course, are going to have an impact on the response to vaccines. If we have a rejection, we are going to use much more immunosuppression, so it's not the correct time to vaccinate a patient. It's recommended to check for seroconversion and to monitor the protective titers, and we should wait at least 4 weeks between the vaccine, the last dose of the vaccine, and the test. The serology, as you know, may not be an accurate measure of immunity in the post-transplant period, but we need much more research on this topic. Assays for cellular immunity would be an important instrument, but we also need more studies about that. Inactivated vaccines after transplant are okay, and we can use it. Most vaccines produce an antibody response, as we have discussed. It probably diminish in certain cases, but the potential benefits outweigh the harm. So it makes sense. But once again, the pre-transplant period is really the window of opportunity. So different countries have different recommendations in terms of vaccines. This is the US recommendations, and the CDC has this great figure that can help us and guide us in the immunosuppressive patients, and also in patients with kidney failure or with heart disease or chronic lung disease. What are the vaccines that are recommended or not recommended? And now we are going to talk a little bit of each one of them. And let's start with the vaccines for COVID-19, because they are really hot topic now. And first, I would like to discuss with you just COVID-19 in pediatric solid organ transplant recipients, because, no, I just lost a slide, don't worry, because I would really like to address with you that in the beginning of the pandemic in 2019, and then afterwards, TransplantChild really united, and we published together a paper just about the first months of the pandemic. And on that paper, we described what was going on and what was happening in terms of our daily life in the kidney transplant centers and the liver transplant centers, and also the non-solid transplant. But we described 5 patients that had COVID-19, and they were solid organ transplant recipients. And all of them had mild disease, and they didn't required intensive care unit, and the immunosuppression was not changed. And this was very important because we were all trying to know what was going on and trying to decide what were our strategies. So TransplantChild had that important publication. Other centers and other studies were published afterwards. For instance, this is a multi-center study whose principal investigator was Dr. Toulouse from Great Ormond Street Hospital. And this is COVID-19 in children immunosuppressed because of kidney disease. Then they had 113 children, and 47% had a kidney transplant. And the conclusions, and lots of centers from TransplantChild also worked together in this paper, and the conclusions were that the great majority had a mild disease. And I really, really would like to highlight the work of Professor Lorenzo D'Antiga from the Pediatric Liver Transplant Unit from Bergamo. It was really important, his work, because as you know, Bergamo was hit by the pandemic really early on, and Professor D'Antiga was publishing what he was seeing with his patients and how mild was the disease, and we were all really reading what he was writing, and his wisdom really guided us through the beginning of the pandemic, because lots of centers were closed. We were closed in Lisbon for a while because there were these concerns about COVID-19 in pediatric solid organ transplant recipients, and we also didn't know if we would have enough spots at the pediatric intensive care unit. And the work from Professor D'Antiga showing us that the recipients of solid organ transplants had mild disease, and that stopping the programs was harming more our children than continuing, was really, really important to get us forward and to restart our activity. This is a paper published by Professor D'Antiga showing that a child, this is really the ideas why children with the infection of SARS-CoV-2 have more mild disease, and also the immunosuppression can help with all of this. So children can have lower receptors in the nasal epithelial, and also the way that they have enhanced interferon gamma activity and interleukin 17A, and the way they have milder monocyte macrophage activation may really have a word about what's going on in terms of the severity of COVID-19. So we all know that in pediatrics, fortunately, we have milder disease, but we still have cases with some morbidity, and it's still important to vaccinate our children, and the benefits are still higher than the risks in this population. And so all solid organ transplant recipients more than 5 years old are eligible for COVID-19 mRNA vaccine. Several studies have shown that the immunogenicity and efficacy of COVID-19 vaccines are lower in this population, but still the benefits are higher than the risks. And the recommendation from these different societies is really delay vaccination for at least 1 month after transplantation, and for at least 3 months after the use of T-cell depleting agents like the anti-thymocyte globulin that we use in certain cases for the induction in transplant, or specific B-cell depletion agents like rituximab. We can vaccinate at least 2 weeks before transplantation, and a third dose for this population is associated with improved immunogenicity and appears to be safe. So it should be given a minimum of 28 days after the second dose. There are some studies showing that probably a fourth dose of the mRNA vaccine may increase antibody levels, but some other studies don't show the same, and some patients that don't respond to 3 doses don't respond to a fourth dose, so this is debatable. And as you know, everything with the pandemic is changing, so these recommendations are always changing, and we are always trying to understand what is the correct and the new recommendation for our patients. So far, and this is the CDC recommendations, in patients more than 5 years old but less than 12 years old, they will have the lower dose of the mRNA vaccine. So the schedule is 2 doses separated by 21 days. And for our immunosuppressed patients, they should have a 3rd dose. And for this age group, the booster is not recommended yet. And for the more than 12 years old, they have the 3 doses, and then they have the booster. And here they have the higher dose. The COVID-19 vaccines can be given with other vaccines. Of course, we have to think the risk benefits about it, but they can be administered and with other vaccines and in the days before and after, but we should use different injection sites. And of course, a different limb with other vaccines that are more likely to cause a local reaction. So now let's go to the influenza vaccine. And the influenza vaccine, it's really, the recommendations are really different from country to country. In the US, it's recommended in every children more than 6 months and annual vaccination. Of course, in the first time that you do it 2 doses, and then you do just 1 dose. But in Europe, and this is data from the ECDC, different countries have different recommendations. Some will just recommend, the general recommendation will be like more than 65 years old. Other countries have different recommendations, and they do it after 7 months. Others just do it when they have risk factors. So it's really, really heterogeneous how the different committee on vaccines from the different countries do it. But in our patients, in solid organ transplant candidates and recipients, the influenza vaccine is recommended. So what we know is that the influenza infection may cause significant morbidity and mortality in transplant recipients. It also increases the risk of rejection. This is a 5-year prospective multicenter study about influenza in transplant recipients. They have more than 600 patients, children and adults. And here it's 477 are solid organ transplant recipients. And what they showed is that 67% were hospitalized and 11% require intensive care. So it's really a big burden of influenza in our patients, and we feel that. So what they showed is that the vaccination in the same influenza season was associated with a decrease in disease severity. So we have, with the vaccination, we have a lower viral load, lower presence of pneumonia, and also lower intensive care unit admission. So these are important data. We have to discuss regarding the influenza vaccine 2 important things. One is the immunogenicity, and the other one is the safety of the influenza vaccine in this group of patients. For the influenza vaccine, we have several vaccine formulations. We have the standard, we have the high dose, we have the MF59 adjuvanted, the live attenuated, but the one that was most studied was really the standard dose. And there is this wide variability of antibody response between different studies, because also different studies studied patients with different ages, different organs, time from transplant was different, immunosuppression drugs used were different. But globally, what we know is that generally healthy controls have a seroconversion that's much higher than the patients that had a transplant and are immunosuppressed. But still, even with lower immunogenicity, the benefits outweigh the risks. There are several strategies that have been studied, try to improve the immunogenicity, like intradermal vaccination, adjuvanted standard dose vaccination, but the data really doesn't show a huge improvement in immunogenicity. And then there are other strategies like booster dosing and high dose vaccine that seem to increase immunogenicity, but we still need more studies. forward. Then we have the safety. And of course, there is this theoretical concern that vaccination can trigger organ rejection, like a virus. It's an immunological trigger, and we all think about that. So far in clinical trials, this association has not been reported. And there is this retrospective cohort study of adult renal transplant recipients, but we are talking about more than 50,000, that the influenza vaccination on the first year after transplant was associated with lower risk of allograft loss and death. So these are all food for thought, so that we can think and discuss what are the strategies in our center about influenza. But the majority of the different associations will highly recommend the influenza vaccine. So recommended to all patients before and after transplantation, the inactivated seasonal influenza vaccine, annual dose, and of course the primer vaccination. And we are talking about 6 months to 9 years old, it's 2 doses 4 weeks apart. And we can start the vaccination as early as 1 month post-transplant, as we already discussed. And for instance, the KDIGO guidelines also recommend influenza vaccine, the inactivated one month post-transplant. So this is the current recommendations, the current knowledge. But of course, we really need more studies understanding the efficacy and the risks about it. But it's really a consensus right now, the use of the influenza vaccine. Regarding the live attenuated influenza vaccine, we can give it pre-transplant at least 2 weeks before transplantation. This is a little bit different. The usually thing for the live attenuated is 4 weeks before transplantation, but with the influenza vaccine, these vaccines are not supposed to replicate at the temperature in our body, so they are considered to be safer, but the recommendation is really 2 weeks before transplantation, they can still be given, not recommended post-transplant, of course, due to this risk of viral replication. And if they are administered to a transplant recipient, it is recommended to give them antiviral therapy and revaccinate with an inactivated influenza vaccine. So now, let's move forward and talk about pneumococcal vaccines. And this is the data from ECDC, what's happening in Europe. All the countries in Europe now, almost all, are recommending the vaccination in the first year of life for pneumococcal disease. And then we have different schedules and different uses of the vaccines. So we have 2 pneumococcal vaccines, the 23-valent polysaccharide vaccine and the 13-valent, which is a protein conjugated vaccine. This one induces a T-cell dependent response. It leads to the production of higher avidity antibodies and to the formation of memory B cells. The polysaccharide, it leads to a T-cell independent response. So the recommended strategy would be give the conjugated, the vaccine, the protein conjugated vaccine, and then after finishing the schedule for the conjugated vaccine, then after 8 weeks, you can give the polysaccharide 23-valent vaccine, and then you can give a booster 5 years after that. I would have to tell you that there are conflicting reports about the impact of this strategy in this group of patients. There is this randomized controlled trial of liver transplant recipients who received the 13-valent and the 23-valent and showed that boosting of the titers with the polysaccharide really didn't happen, but the polysaccharide gives you extra coverage for 10 additional pneumococcal serotypes. So the polysaccharide doesn't seem to be as immunogenic as the 13-valent, but it has additional serotypes, so the strategy is still doing both. Another important issue is that pneumococcal titers have been reported to decline post-transplant, but we still don't know the optimal monitoring strategy and what will be the optimal intervention for these declining titers. Another important thing is that when we give the 13-valent pneumococcal vaccine, we shouldn't give the anti-meningococcal ACWY at the same time. They should be separated at least 4 weeks, because if we give it at the same time, this will lower the pneumococcal titers. Of course, if the child has different doses of the pneumococcal vaccines, we might need to give extra doses. So we should really see the schedules and see what was going on in this child, what was the schedule that this child did, and then we'll see how many doses of the 13-valent vaccine they will need, and then afterwards we'll do the polysaccharide vaccine. So this is what is going on with the pneumococcal vaccines right now, but this may change in the future when we have different vaccines for pneumococcal, which will happen, and all of this can change a little bit. So now, regarding meningococcal vaccines. So the meningococcal disease in Europe, its incidence is different from country to country. For instance, in UK, in Ireland, they have higher incidence of the meningococcal disease, and it also happens in teenagers. For instance, in Portugal, we don't have this peak on teenagers. We have babies, really small babies, and then we have the elderly. So what's happening in terms of epidemiology, of course, it's going to determine what are the vaccine recommendations in the different countries in Europe. So some countries will recommend in the first year of life, and they have in their national vaccine programs, others don't. Other countries will have a vaccine or a booster later on in the teenage years. For instance, we don't. So it's really, of course, the vaccine schedules are going to be different according to the epidemiology. What we know about the meningococcal vaccines in the pediatric solid organ transplant recipients and candidates. So not much. The incidence of meningococcal disease after transplant is unknown. There is no information on the efficacy of these vaccines with renal or liver failure or after transplant. So what we usually do is we just follow what is the national program of vaccines for the country. But the quadrivalent meningococcal, so we are talking about the ACWY and the serogroup B vaccines should be administered to the recipients of solid organ transplants and candidates who have a specific risk factor for invasive meningococcal infection. And we are talking, for instance, about explenia and use of eculizumab. For patients, and for eculizumab is particularly important, for patients who will be starting eculizumab, vaccination should be completed at least 2 weeks in advance in order to provide the adequate immune response. And the majority of them will also give antibiotic prophylaxis even after appropriate vaccination. Then we have the hepatitis B vaccine. And the hepatitis B vaccine is recommended in the majority of countries in Europe, different schedules. And here, if the transplant candidate is non-immune and the titers are below 10, then a hepatitis B vaccine should be given prior to transplantation as early in the course of disease as possible. This is always the major principle. So a 3-dose vaccine series is recommended. We can do an accelerated schedule, but it might be less immunogenic, and then we should monitor titers 4 weeks after the last dose. And then if again the patient has less than 10 of the anti-HBs titers, we can do a complete series again, or giving 1 dose and checking the anti-HBs again. Some centers in adults use high-dose vaccine, and they also use high-dose vaccine in chronic kidney disease. We need more studies in pediatrics to know what will be the right strategy, how many times we should revaccinate, what should we do, what are the doses that we should use, what are the doses of the vaccines and the number of vaccines that we should use. There are here some topics of research still. Frequently, titers decline after transplantation, and booster doses provide suboptimal responses. So we really have to improve what we should do. We have hepatitis A virus vaccine, which is not recommended in the majority of the European countries, but for pediatric solid organ transplant candidates, hepatitis A vaccination is indicated. And we should use 2 doses at 0 and 6 months, and then we should just monitor titers if the individuals are going to endemic area. And again, they should be vaccinated as early as possible in their chronic liver disease, and they should complete the vaccine prior to transplantation. but this vaccine can also be given pause. While combination vaccine with both hepatitis A and hepatitis B may be something that is convenient, it feels to be less immunogenic comparing with the monovalent vaccines. So now HPV, the human papillomavirus vaccine. Different schedules in the different European countries, but the majority of countries, as you can see, recommend the HPV vaccine. The transplant recipients, as we all know, have an increased risk of malignancy related to HPV, so it makes perfect sense to vaccinate our patients. This vaccine is indicated for males and females more than 9 years old, and for the immunosuppressed, a 3-dose vaccine schedule is recommended, 0, 2, and 6 months. And if the doses are not completely pre-transplant, we can give them 3 to 6 months after transplant. But of course, once again, the best is to give them before transplant. Now let's talk about live vaccines. So measles. Measles is, of course, included in all the European country schedules, and as you know, it's a live attenuated vaccine, is contraindicated to post-transplantation. So the field is really changing. All the recommendations would be never, ever, ever use MMR vaccine after transplantation. Now with the different bursts of measles, in very specific patients with very low immunosuppression, the MMR vaccine was given and it was safe, but the recommendation is still not using MMR vaccine after transplantation. The limited safety data, it's really limited in this pool of patients, so we need more data to use it safely. The recommendation is really vaccinate before transplant, and children need 2 doses, and we can anticipate if necessary, and the minimum time of the interval between the 2 doses is 4 weeks, and we should check the titers and give booster if not protected, and the MMR vaccine can be given as early as 6 months. We know it's not going to be as immunogenic, but it can be given as early as 6 months, and then if the transplantation has not occurred by 1 year, we should give a second dose, and the first one will be considered the dose 0, and then the schedule should be given like another child. The MMR vaccine and the varicella vaccine can be given on the same day, but if it's not on the same day, they should be administered at least 28 days apart. And IVIG, plasma, red blood cell transfusion interfere with the efficacy of the MMR vaccine, so we should delay administration between these 2 products. We should monitor titers post-transplantation, and in non-immune solid organ transplant recipients and those who are severely immunocompromised and have been exposed to measles or the MMR vaccine, we should give post-exposure prophylaxis with IVIG. Then, regarding varicella, and we are almost finishing, the varicella vaccine schedule is also very different in Europe. Some countries will offer them, other countries don't. The US gives the varicella vaccine. It's recommended to every child. So here we have, it's really heterogeneous. And the varicella vaccine, as you all know, it's a live attenuated vaccine. It's contraindicated post-transplantation. Like the MMR vaccine, we have very limited safety data, so it's still contraindicated post-transplantation. What we have to do is do serology and vaccine pre-transplant. And once again, minimum of 4 weeks apart from transplantation. This vaccine is a 2 doses vaccine. If we have a child from 12 months to 13 years old, they have to be, the 2 doses have to be apart at least 3 months. And if we have a teenager more than 13 years old, then we just have 4 weeks apart. You can start the vaccine when the child is 9 months. It's not as effective, but you can do it like the MMR strategy that we talked about earlier. And we also should monitor the protective titers. And if we have post-exposure, we can give specific immunoglobulin, and we can give acyclovir or valacyclovir. Regarding travel vaccines, of course, we have to see what's going on in the country that the patient is going to travel. The majority of centers have the travel vaccines appointments that are highly recommended. And of course, if it's a live attenuated vaccine, it shouldn't be administered after transplant. If it's an inactivated vaccine, it will be safe. And then the close contacts. So close contacts of solid organ transplant candidates and recipients should be fully immunized according to the national program of vaccines, and they should get the inactivated influenza vaccine every year. It's better to have the inactivated influenza vaccine than the live attenuated. So if possible, that would be the recommendation. They can receive the live attenuated vaccines of MMR and varicella because that will have more benefits than risks. It's not recommended to have the live oral polio. Regarding pets, they can have all the vaccines, and they should have all the vaccines, including the live attenuated vaccines. What about us? So we work with these patients when we are very close to them. So of course we should have our national immunization program up to date. We should have our annual inactivated influenza vaccine, and we should have the SARS-CoV-2 vaccination up to date in order to also protect them. So in summary, we have to promote complete vaccination very early before transplantation. After transplantation, we have to use the influenza annual vaccine, the seasonal one, the inactivated one. We have to protect our patients against SARS-CoV-2. We have to also see the titers of hepatitis B and revaccinate it. We have to vaccinate also for human papillomavirus. We should not administer live vaccines. And as we discussed, monitor titers and think what's the best strategy if patients are not protected. Then in some cases, we should need to do post-exposure prophylaxis and antiviral therapy. And we have to consider always the vaccination of close contacts and of us, of course. Future research, a lot of things to do. So we have to determine the optimal timing and dosing of immunization in solid organ transplant recipients. What are the doses of the vaccines? Do we need boosters or not? And what happened according to the immunosuppression level of our patients, and what happened if the patient had the vaccine before or after transplant. And we really have to see between different groups of immunosuppressed patients who can receive safely live attenuated vaccines and who cannot. Probably we'll have to divide because of treatment, but also we can use more. We can study what are the immunological status of these patients in terms of their immunoglobulins, in terms of their cell immunity. So we have to really categorize these patients and understand with more detail when it's safe and when it's not safe to give these vaccines. And then, of course, we need new vaccines. For all of us, CMV, BV vaccines would be really important. The Papillomavirus vaccine will be important. So hopefully with the pandemic and all the improvements in the vaccine world, this might be possible faster than what we thought previously. And these are really, really important research topics now. So thank you all for your attention, and please go ahead and ask your questions.